Welcome to Robert Wood Johnson University Hospital Somerset's Health Talk. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. In accordance with social distancing due to the COVID-19 pandemic, I am hosting this show from the studio, and our guest will be joining us remotely via video conferencing. Each year, about 1.8 million new cancer cases are diagnosed in the United States. The most common cancers among women are breast, lung, and colorectal cancers, which make up 50% of all cancer cases. During today's show, we will talk more about what women can do to prevent cancer, including important cancer screenings. We are joined by a special guest, Dr. Faye Yin, a medical oncologist hematologist with Robert Wood Johnson University Hospital Somerset's Steeplechase Cancer Center and the RWJBarnabas Health Medical Group. Welcome to the show. Thank you, Dr. Yin, for being here. First, let's start off. The audience would like to know a little background about yourself, where you went to medical school, residency, et cetera, and how you got affiliated with RWJBarnabas Health.
Thank you. It's a great pleasure to be here. So I received my medical education in China and was a hematologist, oncologist prior to coming to the United States. I repeated my training, including internal medicine residency and my specialty training of hematology oncology fellowship, which was at the NIH and the National Cancer Institute. So I worked as a community oncologist in Maryland for 7 years and moved to New Jersey in 2020. As a female oncologist, I see many patients with breast cancer and the female cancers, such as uterine cancer, cervical cancer. So the hospital I worked at, Jersey City Medical Center and the RWJ University Somerset Hospital, we all have an association with our CINJ, the Cancer Institute.
Thank you very much, and thank you for all of that expertise. My gosh, all of that schooling and everything you've done, including the NIH. Congratulations. First, let's start off. The audience has heard the word cancer multiple times. Tell us what the word cancer means and what happens in our body.
Cancer affects 1 in 3 people in the United States. We are made of trillions of cells that over our lifetime normally grow and divide as needed. When cells are abnormal or get old, they usually die. Cancer starts when something goes wrong in this process and the cells keep making new cells, and the old or abnormal ones don't die when they should. As the cancer cells grow out of control, they can crowd out normal cells. This makes it hard for our body to work the way it should.
So what we're describing is abnormal growth or irregular growth of unusual cells. So it's the cells that either should have passed, or should have died, or ones that may be genetically different than the normal cells, and those cells keep on multiplying, and that's basically what a cancer is.
Yeah.
And now, as we had mentioned in the introduction, we're going to be talking about the common cancers in women. Those common cancers are breast cancer, lung cancer, and colorectal cancer. Can you go through each line of cancers one by one, discuss each one, the risk factors for it, and what can be done to help prevent cancers, and of course the screening options? And if we don't get to the screening options now, we'll do that down the road. So first, breast cancer.
Sure. So breast cancer. So who is at a risk? We start that. Being a woman is at a risk for breast cancer. As you know, there is 1 in 8 chances for American women to develop breast cancer. Some of the risk factors which can't be changed, such as getting older, family history of breast cancer, genetics, race, ethnicity, having dense breast tissue, certain benign breast conditions, previous radiation exposure to chest, starting menstrual periods early, or going through menopause later, or that just say your body has more exposure to estrogen. Other risk factors may be changed, such as being overweight, drinking too much alcohol, lack of exercise, not having children, not breastfeeding, using some birth control methods, such as hormones and hormone replacement therapy for menopausal symptoms. They are tiny risks, just adding on. So that's something we are trying to prevent. They are considered as risks.
So again, the big risks are, of course, the family history of breast cancer. And again, anything that helps medical care, such as not being overweight, maintaining blood pressure, eating more vegetarian diet than a high fat, high protein diet, reduction of cigarette smoking. Those things can help reduce the risk of breast cancer.
Yes.
And then, of course, the screening options. Now, can you tell us what the most recent guidelines on screening options are? Those things constantly change. The science changes periodically. Years ago, it used to be different. So can you let the women know what the current guidelines are for screening?
So first of all, the screening options. So the mammograms, you heard about 2D versus 3D mammograms. So many studies have found that 3D mammography appears to lower the chance of being called back after screening for follow-up testing. It also appears to find more breast cancers, and several studies have shown it can be helpful in women with more dense breasts. A large study is now in process to better compare outcomes between 3D mammograms and the standard 2D mammograms. It should be noted that 3D mammograms often cost more than 2D mammograms, and this added cost may not be covered by insurance. So other including clinical breast exam and the breast self-exam. So it is not mandatory, but it is good for women to be familiar with how their breasts look and feel. They are encouraged to report any changes to their health care provider. Women who are at higher risk for breast cancer should get a breast MRI and a mammogram every year, typically starting at age 30. So this includes the population who has high risk, which means have a lifetime risk of breast cancer of 20 to 25% or greater, according to the risk assessment tools that are based mainly on family history. Or you have a known BRCA1 or BRCA2 gene mutation, or you have a first degree relative, such as parents, brother, sister, or child with a BRCA1 or BRCA2 gene mutation and have not had genetic testing themselves. Or had the radiation therapy to the chest when they were younger than age 30, or some rare genetic mutations. So those people are considered as a high risk for breast cancer and requires more close screening. That's about the screening options.
So again, the good news, first of all, for women out there who are listening to this program, RWJBarnabas Health at the Steeplechase Cancer Center does all of those type of testing, including the 3D mammogram, the normal mammogram, as well as the MRI. They also have nurse navigators who help you through the breast cancer risk assessment to determine the best screening options, and that it can be done right there on site. And again, what we want to recommend is for the women who have normal risk factors for breast cancer, starting breast cancer mammograms, hopefully the 3D if their insurance covers it. If not, there is an option that they can pay that out of pocket, but it does reduce the risk of them coming back for a second repeat mammogram, as well as helps with the density, the breast density issues. And again, starting regular women with normal risks around age 40. Those who have higher risks, as you had described, the BRCA1, the BRCA2, people who've had previous nodules, or anyone who has a direct family who has had breast cancer before the age of 40 or who received radiation therapy, we do it sooner than that and consider MRI at the same time. Years ago, we used to also insist that women do breast self-exams on themselves. That's no longer an insistence, but women who do breast self-exams on themselves monthly sometimes do find things that are not seen in a mammogram, and that also helps reduce the risk of missing something. So a woman doing it once a month, standing in the shower, and then doing it laying down flat, she can figure out the contour of her breasts. And then if there are any changes or abnormalities, they usually are very sensitive to it and sometimes can find it before we do a mammogram.
Yep. And the guidelines, as you know, we have different guidelines regarding when and how often on breast screening. The American Cancer Society screening recommendations for women at average breast cancer risk to start screening a mammogram every year at age 40 and 44. After age 55, can switch to a mammogram every other year or continue yearly mammograms. Screening should continue as long as a woman is in good health and is expected to live at least 10 more years. So it's not like a 75, you have to stop. If you think you can live for another 10 years in good health, you still can continue on mammogram.
Thank you. Now we're going to shift over to lung cancer. Again, who is at risk? Which women should do to prevent lung cancer, and then the screening options that we have.
So who is at risk? So anyone who smokes tobacco is at risk for lung cancer. So about 80% of lung cancer deaths are thought to result from smoking. The longer you smoke and the more packs a day you smoke, the greater your risk. Secondhand smoke can also increase the risk of developing a lung cancer. So other risk factors include exposure to radon. As you know, radon, according to the EPA, is the second leading cause of lung cancer in our country and is the leading cause among people who don't smoke. People who work with asbestos, such as the mines, mills, textile plants, places where insulation is used, and shipyards are several times more likely to die of lung cancer. Exposure to other cancer-causing agents in workplace, such as, there are a lot. Radioactive ores such as uranium, diesel exhaust. Somewhere, we talked about certain diet, so such as beta carotene supplements may increase risk of lung cancer in people who smoke. Arsenic in drinking water. The above are risk factors you may change. There are risk factors you cannot change, which include previous radiation therapy to the lungs, air pollution, personal or family history of lung cancer.
Okay, so again, the things that we want to do is the biggest risk factor of all is cigarette smoking. And again, if we can reduce the person or stop the person from smoking, that helps immensely and really will reduce the risk of developing lung cancer. Anyone who deals with any type of radioactive material or who, when they buy a house, does a radon check, should make sure that the levels are within normal limits so that you don't increase the risk from radon. And then, of course, lastly is the asbestos exposure and pleural cancers from asbestos exposure. It's not as high as it was 20, 30 years ago, but it's still something that has to be thought of in the older person who may have worked in a mill that was doing insulation. because prior to years ago, we used to use lots of asbestos in insulation, and it used to float all over the place. So at the RWJBarnabas Health Steeplechase Cancer Center, what is the screening that we use over there for people who we think are at risk of lung cancer, or who we're just doing a lung cancer screening on? Years ago, we used to, of course, do chest x-rays on patients coming in for yearly physicals, but many years ago, the study showed us that by the time it showed up on a chest x-ray, it was usually too late. So that's why we've gone to other types of screening modalities. And at RWJBarnabas Health Steeplechase Cancer Center, those screenings are?
Oh, yeah, we have a lung cancer prevention program. We really have a designated doctor and staff to do that. So we follow the American Cancer Society lung cancer screening guideline, which was updated in 2018. Anyone who is 50 to 80 years old and in fairly good health and currently smoke or have quit in the past 15 years and have at least a 20-pack year smoking history, which means the number of packs of cigarettes per day multiplied by the number of the years smoked. For example, someone who smoked 2 packs a day for 10 years, that's 20-pack years of smoking, as does a person who smoked 1 pack a day for 20 years, that's also 20-pack year of smoking. So by the way, screening is not a good alternative to stop smoking. By quitting, people who smoke can lower their risk of getting and dying from lung cancer.
Which again, at RWJBarnabas Health, we do have the smoking cessation program. So anyone who's listening to this and has any thoughts about quitting smoking should contact RWJBarnabas Health to be enrolled in the smoking cessation program. So if we've got someone who has had 20 plus pack a year, age 50, and has smoked within the last 15 years, what is your suggestion for them?
So that's a low dose of a CT scan. So it's a much lower dose of X-ray exposure. It's once a year. Those population can follow with our lung cancer program.
Which again, at the RWJBarnabas Steeplechase Cancer Center, we have the low dose lung cancer screening. Again, when you call up the number, a nurse navigator will get on the line with you, go over the details, and figure out whether or not they believe that you are or are not a candidate for the test. And if you are a candidate for the test, they will also contact the insurance company to ensure that it is pre-certified so that the insurance helps cover that screening. Then we do the low dose CT scan. Again, low dose meaning that unlike the regular CT scan, you're not absorbing the radiation levels that you would at a regular CT scan. And then the report is usually given to both the primary care physician as well as a pulmonary person. And an interpretation is then usually either the pulmonary person or the primary care can then relate that report to the patient, as well as that report going into the patient's MyChart, which is part of the Epic system, so the person can actually read it themselves. And usually it'll give you advice on what the risks are, if they saw any nodules, and what the considered the follow-up is. Is that correct?
Yes, that's great, yes.
And usually if the person is a 20-pack a day smoker or more, and there's any concerns, usually the interpretation will also recommend a repeat done in approximately a year.
Yes.
And what's good about it is that, again, we're going to catch things early. And the one thing to know in cancer is that if we do catch things early, there's things that we can do that are much less invasive, much less debilitating to the patient, and we can put the person into remission or even consider the person cured after finding things such as that.
Mm-hmm.
But again, the big thing that we need to let people know is that we do have these great screening modalities. We have terrific hematology, oncology, pulmonary, and primary care people who are part of RWJBarnabas Health. But the most important thing is to improve your health. Follow a good low cholesterol, low fat diet, increase the amount of vegetables in your diet. But if you do smoke, figure out some modality to give up the cigarettes. And if necessary, please call us at RWJBarnabas Health and enroll in the smoking cessation program. Now let's move on to colorectal cancer. So who is at risk for colorectal cancer? What can women do to prevent colorectal cancer? The screening options?
So colorectal cancer is the second most common cancer in non-smokers. So the risk factors you cannot change include being older, everybody's getting older, a personal history of colorectal polyps or colorectal cancer, a personal history of inflammatory bowel disease such as ulcerative colitis or Crohn's disease, a family history of colorectal cancer and adenomatous polyps such as Lynch syndrome. That's a hereditary polyposis colorectal cancer, Lynch syndrome, and the familial adenomatous polyposis, that's FAP syndrome. But other rare syndromes can also increase the colorectal cancer risk. Racial and ethnic background matters, such as African Americans have the highest colorectal cancer incidence and the mortality rates of all racial groups in the United States. Colorectal cancer risk factors you can change include being overweight, not being physically active, certain types of diets that high in red meats, and the processed meats raises the colorectal cancer risk. Having a low blood level of vitamin D may also increase your risk. People who have smoked tobacco for a long time are more likely than people who don't smoke to develop and die from colorectal cancer. Colorectal cancer has been linked to moderate to heavy alcohol use.
So again, the same things like for lung cancer, breast cancer. Stay as active as possible, keep in good shape, maintain good blood pressure, reduce the processed meats, reduce the red meats, and increase the vegetables in our diets. Also, if there's any family history of polyps, it's more important to be screened more frequently or earlier. If there's a family history of colon cancer, again, screening earlier and more frequently. If you have ulcerative colitis, Crohn's disease, that also increases the risk of colon cancer. And thus, again, following up with your gastroenterologist or colorectal surgeon and doing more frequent screenings. For the average person with no increased risk of colon cancer, again, the suggestion is?
Screening, the American Cancer Society recommends that people at average risk of colorectal cancer start regular screening at age 45. In the past was 50. This can be done either a stool-based test or colonoscopy. People who are in good health and with a life expectancy of more than 10 years should continue regular colorectal cancer screening through the age of 75. For people aged 76 through 85, the decision to be screened should be based on a person's preferences, life expectancy, overall health, and prior screening history. People over 85 should no longer get a colorectal cancer screening. If you have a strong family history, as mentioned before, screening recommendations may depend on who in the family had cancer and how old they were when it was diagnosed. Some people with a family history may need to get a colonoscopy more often and at an early age, so that needs to be discussed with your doctor.
So the important thing is, one, discussion of all of the risk factors, family history, et cetera, with the patient's primary care and or referral to a gastroenterologist or a colorectal surgeon. Consideration and starting cancer screening earlier at age 45 rather than the previous age 50. consideration of screening tests including Cologuard or fecal immunochemistry tests. If it's a Cologuard, every 2 years, a fecal immunochemistry test every year. Consideration of a colonoscopy either at age 45 or at age 50. And then based on the results of the colonoscopy, follow-up colonoscopies, again, based on what they see at that time. And the good thing about a colonoscopy is if the gastroenterologist or the colorectal specialist sees a polyp, while they are doing the colonoscopy, they're able to easily remove the polyp, send it off for pathology, so that instead of having 2 procedures done, 1 is done, and we can follow up based on the results of the pathology. So the important things for women out there for breast cancer, lung cancer, colorectal cancer, and all cancers is, 1, a good discussion with their primary care physician. And if there's any concerns about increased cancer, the primary care physician should refer them to the RWJBarnabas Health Steeplechase Cancer Center. And what's wonderful about the Steeplechase Cancer Center is that they're affiliated with the Rutgers Cancer Institute of New Jersey, and it's the state's only NIC designated comprehensive cancer center. So what does that mean for the audience?
So the affiliation with the Rutgers Cancer Institute of New Jersey emphasizes on clinical research and the cutting edge of treatment, enabling those who need cancer treatment can receive the best cancer care close to home. Our patients have the access to the latest medicines and the technology, as well as the most advanced clinical trials, including novel, personalized, targeted therapies and immunotherapy at the Steeplechase Cancer Center through the affiliation with the Rutgers Cancer Institute of New Jersey.
So what we're doing is we are giving them the best possible treatment, the most up-to-date treatment, including any types of studies, and it's being done at a local facility. So rather than having to commute into a large metropolis area, trying to find parking, unable to get to the social service help, or if something needs to be followed up, it's very difficult to do that from a faraway metropolis center. Here, we can do it right here in RWJBarnabas Health Steeplechase Cancer Center, and they are getting the latest, best treatment at a local facility.
Yep.
And again, that means a lot to when someone hears that word cancer. Most people don't hear anything else after that word. And it's very, very difficult to arrange to do things, to get everything put together. At RWJBarnabas Health Steeplechase Cancer Center, they're in touch with a nurse navigator who helps them get through the system, gets through all of the red tape, gets them the social service, gets them everything that's necessary. It's something that's so remarkable compared to just sending them to an oncologist. So I have to applaud you, your facility, the Steeplechase Cancer Center, and the fact that you're affiliated with the Rutgers Cancer Institute of New Jersey, being the state's only NCI designated comprehensive cancer center. I have to applaud for everything that you do every day of the week.
Yes, yeah, our cancer center is accredited by the American College of Surgeons and is a certified comprehensive community cancer center. So with the affiliation, that's just add a lot of new things. And then we are really comprehensive, for example, the breast cancer program, we have multidisciplinary team of medical oncologists, surgical oncologists, plastic and reconstructive surgeons, radiation oncologists, radiologists, pathologists, genetic counseling, even the, of course, the nutrition, social worker, pharmacist. We even have scalp cooling therapists, pastoral care, and our team meets every week to discuss each newly diagnosed cancer or breast cancer, creating individual treatment plans for our patients.
Thank you very much for being here. Thank you for the thorough discussion of the cancers that are in women, and thank you for everything that you do every day of the week. That concludes today's episode of Health Talk. Please remember that the opinions shared here today by our medical expert are not a substitute for medical advice from a physician. If you need a physician, please call 888-724-7123. For more information about cancer services at Robert Wood Johnson University Hospital, Somerset, visit us at www.rwjbh.org/Somerset.